Okay, PhysioEx 11, activity 1. That first activity, we were determining hematocrit. From yesterday, since you did hematocrit on my blood, did I come out to be normal hematocrit, by the way? Pretty normal? Was I in the 40s? Yes? Ish? Was I at least 38?
Yeah.
38. Oh yeah, 38.
So for women, normal range is around 37 up to about 42, something like that. Was I somewhat in normal range? Okay, good. Hematocrit is a division problem. We are dividing the red blood cell column, which you should have measured in millimeters, dividing that by the entire whole blood column, again in millimeters. It is a percentage, and yesterday you also calculated my true hematocrit. You multiplied the hematocrit by 0.96 to adjust for any leftover plasma that could be stuck in between the red blood cell column. In this activity, we were looking at a few people. We were looking at some people living in Boston versus Denver. What's the significance about where they were living? Elevation, right? So what do we know the kidneys will do if we go to elevation? They're going to release EPO. So the individuals that were living in Denver, they had a higher hematocrit. This is polycythemia, but what kind? Secondary. It is considered to be an adaptive response. Do we do anything about this? No, it's an adaptive physiologic change. We also looked at male versus female. And the male had a higher hematocrit than the female. Why is that? They have testosterone, which stimulates the hemocytoblasts more. Men are bigger creatures on average than women. They have more blood volume, so it stands to reason that they're going to have a slightly higher hematocrit as well. Then we saw someone who had iron deficiency anemia. You should have seen that the hematocrit was definitely compromised. It was low. Is that the only test we should do to determine if that person is anemic? And is that test sufficient enough to tell us what kind of anemia they had? No. In fact, in your lab manuals, there are questions about, can we get away with one test to determine if someone is anemic? No, we do multiple tests, and we even send the blood to the lab so that they can analyze the size and the shape and the color index of the red blood cell. Yesterday, you could not finish those calculations to determine MCH and MCV because you needed the red blood cell counts. We will be doing that lab next week. So to be continued.
A question along that line, could you, if a test comes out normal, start to rule out some versions of anemia, or could you trust the test enough to do that? Like, for example, when we're doing the grams percent hemoglobin and it comes out normal, could you start to maybe rule out, probably not iron deficiency anemia, probably not.
If the grams percent is fine, how do we calculate oxygen carrying capacity? We take grams percent, we multiply by 1.34. So if the grams percent is in normal range, then that's not anemia. Right?
Oh, with only the one hepatitis?
Mm-hmm. So if that comes out to be fine, then we're not really worried. It's the grams percent that really determines oxygen carrying capacity. If that's low, we need to figure out why. What kind of anemia is that now?
Okay.
For example, you started the question with Tallquist. If we had started the question with red blood cell count comes out to be fine, do we stop? No, someone can have a normal red blood cell count and the red blood cells might not be filled appropriately with hemoglobin. In which case, if that is true, then their oxygen carrying capacity would be compromised. That's the definition of anemia. you started the question with the Tallquist test, which is hemoglobin grams %. If that's fine, boom, done, end of story. They don't have anemia. You're welcome. Okay, and then the aplastic anemia. In that individual, they had bone marrow failure. Not only was their hematocrit low, but also their white blood cell count was low. So if you noticed, it was less than 1%. Right? It was very low because all of the formed elements were compromised. Could you also predict what kind of bleeding issues this person might have if all of the formed elements are compromised? Would their clotting times increase or decrease? Increase. So it would take them longer to clot because they also have fewer thrombocytes if they have bone marrow failure. Are there any questions about that? Even the review sheets? No. Okay, well then how about activity? Yes.
For question 3,
What page, please?
162.
Thank you.
Why would she have, because I got it was polycythemia, but why would her voice be deeper?
Why is she getting the polycythemia?
The high altitudes and the athletic training.
So in this, explain how a female could have a consistent hematocrit of 48, large, well-defined skeletal muscles, and an abnormally deep voice. What is she doing?
Training.
Probably not in a legitimate way. She's probably doping, isn't she? Probably on anabolic steroids. If any of you are watching the news lately, this is definitely becoming an issue in the running world, isn't it? So how we determine who competes with women versus with men is becoming a very sticky situation because there is a marathon runner and she has naturally high levels of testosterone, which is giving her an advantage. Absolutely. And the athletic venues are trying to make new rules to adjust for that. And you can understand her point. She's like, I am female. I have this advantage, but it's natural. And I should be able to compete with other women. And I understand that. I also understand the rest of the women that she's competing with saying, although it's a natural issue and it is an advantage, but she's in this like 10th percentile, category. How do we even address that? That is going to be interesting how they tackle this. I don't know what the right answer is. Okay. Activity 2. Erythrocyte sedimentation rate, ESRs. You learned about ESRs. Where's my little ESR? ESR. We fill these tubes up with blood and we let them settle for an hour and we come back and we see how much plasma is up at the top. Does this indicate a specific disease state? Nope, it is non-specific. It's quick and dirty, as I like to say. If it's an abnormal result, it merely is suggestive that we should do further testing to find out what's going on. In the activity 2, we looked at a few people that had anemias. And in some of them, their ESR was very low, meaning the red blood cells didn't settle. And in others, they did. So what kind of anemia will get a faster than normal ESR versus significantly slower? In the sickle cell anemia patient, they didn't tell you this, but based on the results, they must have been in the sickled state. So if they're sickled and they're this half moon shape, like I showed you in my little PowerPoint. They can kind of start clustering together and obstruct blood vessels. Well, they can also obstruct each other from falling to the bottom of the tube. They can kind of stick to the sides of the tube and create this scaffold. With iron deficiency, the red blood cells are small. And if they're small, they're not getting in each other's way, and they all can start settling much more rapidly than normal red blood cells. And then we also saw a person with chest pain versus myocardial infarction. And there was a huge difference between those two people. When there is a myocardial infarction, the cardiocytes that are dying, they release distress signals. And one of these distress signals is called C-Reactive Protein, or CRP. And C-reactive protein is part of the inflammation process. And these proteins can actually cause red blood cells to stack together, much like a stack of coins. Now, if you were to throw a penny into the fountain to make a wish, what does it look like when you throw it into the fountain of water as it goes down to the bottom of this fountain? It kind of feathers its way through the water. But if you were to take a stack of pennies, like a bankroll, and throw that in the fountain, would it feather its way through? What is it going to do? Kerplunk down to the bottom. So when we have inflammatory proteins like CRP, it can cause the red blood cells to stack like coins, which means now they're heavy and they sink to the bottom of the tube much more rapidly. That stacked formation is called a rouleau formation. The person who had chest pains was not having the cells release these inflammation markers. They were having chest pains for some other reason, and students often say, well, what can cause chest pains that's not a heart attack? And I said, okay, I will tell you. Have you ever been coughing so much, so hard that you start to have chest pains? That is a very common thing to drive someone to the hospital. This happened to my husband. He was sick, and he had been sick, coughing a lot, but he was also on blood pressure medication, where a side effect was that it was also causing him to cough. So between the medication and him being sick, his coughing muscles, his respiratory muscles were taxed, and he started having chest pain. So he told me that he was going to call his doctor's office to make an appointment to find out, what's causing this chest pain. Should I be concerned? And I laughed at him. I said, they're not going to see you. And because I teach this for a living, I clearly have no idea what I'm talking about. And he called them and he said, I need to make an appointment. Okay, and what are we seeing you for today? And he's like, well, I'm having chest pain. And I sat there like this. Sure enough, they were like, you will go straight to the emergency room. You will not pass go. You're not going to collect $200. And that's like the golden ticket. If you show up in the emergency room and you say you have chest pain, that's one of a few things where you are not waiting 4 hours to be triaged. You go straight to the back room and you are being triaged, because time is not on your side if you're having a heart attack. Sure enough, he ended up in the emergency room. I feel so stupid. All of his blood work, they did a rouleau test, they had his EKG on him. By the time I got to him, because I was prepared for the worst, I had pajamas, I had magazines, I was ready for the long haul, right? By the time I got to him, they were disconnecting him. I feel so stupid. If I ever have chest pains again, I'm never going to go to the emergency room. And I went, time out. That is exactly what we don't want you to do. Well, I feel stupid. No one thinks of you as stupid. You did the right thing. You did what your doctor told you to do. This is what we do when we have chest pain. So his ESR was just fine. Yes.
That happened to me, but I was actually at work at Mission on the 3rd floor. My blood pressure shot up to like 170s, which has never happened to me before. And I was having chest pain, so they sent me downstairs, and I went straight back, did all the blood work, EKG.
Oh yeah.
And then they made me wait 4 hours to tell me, oh, you're fine.
Yep.
You can go home. Like,
because they want to monitor you.
Just in case.
I
think I had too much. I had like a monster drink plus coffee. And I was also like panicking over something, so it was just like a bad combination.
And we'll talk about how coffee and those caffeinated drinks can do that.
Yep.
And when we get to that lecture, I'll also tell you about one of my young students that had a heart attack, had a stent put in. He was in class telling me, Kara, I'm having chest pains. And I was like, you know what to do. Yeah, but I already have my stent. I don't give a shit. You can still have another heart attack. But I just had it evaluated. I still had, whatever percent he told me blood flow. I'm like, I don't care. If you're having chest pain, you go. And he went, and they said, because he was, prior to him having a heart attack, he would go pretty rarely with chest pains because he'd have anxiety attacks. And so then they started labeling him as drug-seeking behavior patient for anti-anxiety drugs. So he was like, I don't want to go. They're just going to, I said, you need to go. So he went, and they dismissed him saying, nope, it's just an anxiety attack, blah, blah, blah. Comes back the next week, he's got chest pain. I said, Brock, you need to go. You need to go. You need to convince them that this is real. You're not having an anxiety attack. So he goes, they have to hook him up. While they're watching him, he gets up out of the bed and starts exercising in the emergency room because heart rate goes up. And when heart rate goes up, it does not get as much blood flow. You'll learn why when we get to Unit 3. And when the heart is working harder and not getting as much blood flow, especially if there's an obstruction, then the tissue becomes hypoxic, anoxic, and you start to have another infarct. So he was literally pushing himself in the emergency room to cause all the signs and symptoms, and sure enough, he had to go into surgery and get another stent. I know. So ESR, it is not a specific test. It is not diagnostic, but we use it, as the introduction to that section said, to monitor the progression of a disease state. For example, rheumatoid arthritis. Arthritis being an inflammatory response, if you're having a flare-up of that, your ESR would go up. You would have the rouleau formation, and those red blood cells would fall to the bottom of the column. If we put you on cortisol, we know that cortisol tempers your immune response, then the ESR should improve. And that's how we mostly use the ESR test, is to monitor how a patient is responding to their medications, especially if they have a chronic inflammatory disorder. Okay. Going on to the next activity. The next activity, hemoglobin grams percent. Now that ESR, by the way, that was part of our molecular technique. So if you have not done that one yet, I forget when I assign it, but if you've done it, good. If you haven't, go ahead and do it because it was part of our molecular techniques. But exercise 3 is your hemoglobin grams percent test. You did not use a Tallquist paper in this test, but you used a different machine called a hemoglobinometer. We have them here. It's just that for little things that have a color filter, so the Tallquist test didn't have color, but you used a color swatch, didn't you? So the hemoglobinometer, it had the green filter, and you had to adjust the lever to match the green color. So it's still a color match. We have those. It's just for these tiny little machines that are like a little viewing picture thing. They're very expensive and they break. They're very sensitive. So now they're part of our museum and we use the Tallquist test, which is a lot cheaper. It's a similar type of test. You're looking for the grams percent. And again, in this, we had healthy individuals. We looked at male versus female. Females would have a lower hemoglobin grams percent than men. For our class, the normal values are 14 to 16%. And we also looked at a person with iron deficiency anemia, a male with polycythemia, and a female Olympic athlete. In your data, please do not worry about the column that says ratio of PCV to HB. Do not worry about that. Although it is not new to you, it is a gram to volume ratio. I picked a different gram to volume ratio to abuse you with, and that was MCHC equals MCH divided by MCV. They did not use the same example, and that's why I'm saying don't worry about their column then. No shock that the female had a lower hemoglobin grams percent than the male. No shock that the female with iron deficiency, her cells were hypochromic, microcytic. They are not well filled with hemoglobin. She definitely has anemia, a reduced oxygen carrying capacity. Then we had a male with polycythemia. We assume it would be polycythemia vera. He had a higher grams percent from having more red blood cells. Now the kicker was the female that had a higher hemoglobin grams percent than the male with polycythemia. She was an athlete. So what does this suggest that she's probably doing? Doping. She's probably using anabolic steroids. Then I've had a student say, well, maybe she's training at elevation. Okay, let's assume the male with polycythemia has secondary polycythemia. Maybe he lives at elevation. And you're telling me that traditionally females have a lower hemoglobin grams percent than males, and here's a female also at elevation who now has more than the male? I'm going to say there's probably something else she's doing. And given a previous question that we just addressed, that's exactly what they want us to assume, that she is taking anabolic steroids. Okay, activity 4. Activity 4. What blood types did you all have? I want you all to shout them out, one person at a time, going down the column. Who did it? Diana, did you do it? What blood types did you get? Rattle them off.
A positive, B positive, AB negative, O negative, AB positive, B negative.
Does everyone agree with that? Okay. Now I'm going to one-up that. You looked for agglutination in those patients to determine their blood types. Here's my challenge to you. Make, on another piece of paper, additional columns. Now that you know what blood types they are, tell me what agglutinins they have. What antibodies do they have? Also tell me what blood type can they safely receive? And also tell me what blood types can they safely donate to? So what agglutinins do they have? What blood type can they receive? Whom could they donate to? And if you could answer, fill in those 3 extra columns, then you really know your blood typing. That's my challenge to you. Okay? Please bring your PhysioEx also next week. We have more to discuss. And again, those are the extra columns that I just told you. That's my recommendation. You don't have to do it. What agglutinins do they have? What blood types can they receive? What blood types can they donate to? I'll see you in lecture.